This is Wellness by Designs, and I'm your host, Andrew Whitfield Cook. Today we're joined by Kate Carr, a functional nutritionist who cares about pre-pregnancy and postpartum nutritional care for her patients. Welcome to Wellness by Designs, Kate. How are you going?
I'm well, thanks, Andrew. How are you?
I'm really well, thank you. Thank you so much for joining us today. I know you're very busy with your practice. Now, I want to warn everyone first that this could be a little bit of a detailed podcast. So if we run out of time, Kate, are you amenable to rejoin us back on Wellness by Design at another stage? Is that okay?
Yes, that'd be wonderful.
Wonderful. Preface is set. So, Kate, let's start with your approach to care.
So, Andrew, I deal primarily with fertility. So reproductive medicine is sort of where I like to angle my sort of passion, and it's dealing with preconception, pregnancy, postpartum. And I guess the whole way that I approach it is to thrive and not survive the whole journey of pregnancy. When women are able to, feel better about themselves during and after a birth, also during the pregnancy, it's all about enabling them that power to enjoy the process, because life is too short. So if we can thrive, then ultimately we've got a happy woman and a happy baby.
So how early do you see not just women, but couples along their pregnancy journey? Like, do you specialize in the pre-fertility area and follow them right through? Or do you see many patients really at this, I was going to say postpartum, that's wrong, at their pre-pregnancy stage?
The best cases is always when they come to see me prior to wanting to conceive. So that could be 6 months, a year, 18 months prior. There's some really women out there who are quite aware that there's more involved than just the act of conception. So ideally that's the time frame, but I must admit a lot of women probably do, and couples seek me out when they want to be pregnant yesterday, and they've been trying for a few months. And with those women and couples, then it's a case that I'll see them throughout their journey. And in third trimester, we really try to work hard to set them up for postpartum as well.
Gotcha. Okay. But when we're talking about preconception care, the immediate, it's almost misogynistic to think it's almost like, oh, well, that's the woman's job. No, it's not. There's a male involved in this as well. The message that we've been taught, though, is that we need to see the male far earlier than the female because of spermatogenesis and the processes that go on there, how long it takes for a good sperm to be formed, if you like. Can you take us through this timeline of when you would preferentially see patients, both male and female, and what's the prep timeline for them?
This is where it can go down the rabbit hole, Andrew, and it's how long do you have? Look, we're very good at trying to make people feel better about themselves and the situation. When it comes to evolution, the ovary hasn't changed. For women, for girls, we're born with a X amount of eggs, and this comes in utero from your mother. By the time we get to age 30, we potentially are down to 95% of some of our eggs, and it just goes downhill from there. So if we did a better job at educating on pregnancy or preconception as opposed to sort of preventing pregnancy, I feel we could have a better outlook on this in society, because you're right. Men will come in and they will be the last one to come in, or they'll be forced to come in, or it's a case of the woman has to convey the message to the husband after the consultation. And that comes from the idea that sperm does regenerate, and it takes 3 months worth of really good sort of a preconception protocol with supplements, good diet, no alcohol, no mobile phone in your pocket, no laptop on your lap. That can really help change things dramatically for a male. However, for a woman, we're born with what eggs we have, and the reality is the longer they're on the shelf, the quality declines. So my goal is, when working with any woman, it doesn't matter what quantity is left, let's make that quantity optimal. And that the energy that's required, the mitochondrial aspect of, the oocyte itself, is astronomical. It's more than one heartbeat, the energy that's required in that transformation. So we say 120 days, and that's 120 days, not for that egg to, burst from the follicle, but to actually really accumulate so much energy to allow it to be its absolute best and retain nutrients and have everything on sort of standby. So 120 days, but ideally it's a lot longer than that.
Yeah, but that's flipped on its head, that notion that it's the sperm that has the energy. It's the sperm that has the, stacked mitochondria behind the head, in front of the tail, so that it can wiggle its way forward in the millions that only one will. So there's this whole concept of energy is the male thing. We're talking about that there's a substantial amount of energy required for the egg.
Yeah.
This is the whole flip.
The research today, we're very much, it's about, women power, and it's the women's egg that chooses the sperm, not which sperm is the strongest and breaks through. It's now, which egg will we decide, which sperm will we allow to come through?
Can we discuss that a little bit? Because this is so interesting about, and it's a lesson that men need to learn, really. It's the woman that chooses, or it's the egg that chooses the male sperm, not the strongest sperm that gets through.
Yeah, correct.
Can we talk a little bit about this? What are the mechanisms that govern this?
The mechanisms, it's still very unknown, Andrew. We still don't completely know, and this is where there's a little bit of magic in fertility. There's, of course, everything from microbiome to, actual genetics here at play, but I can't say I have a definitive answer as to how that actually unfolds. I just know that's where we're at in our discovery of conception.
It's a pity there's not a questionnaire there saying, will you do the washing up? Will you unstack the dishwasher?
Exactly.
Yeah. So I know we've sort of got off track there, but tell us a little bit about the assessments that you use with couples when we're talking about both male and female issues with spermatogenesis, and God, I hope I'm going to get this right, ovogenesis, that's wrong. Oogenesis. Can you talk us a little bit about the assessments that you have for both couples, and particularly given that, as you say, it's mainly women that come and see you, the men have to be dragged along. Do you send a questionnaire home with the female, with the woman, I should say?
This comes a lot in the preconception sort of questionnaire that I send out to couples or women before they come to see me, so they really know how detailed I want to get with them. And this is not just about what blood work they have or what other prior testing. It really comes down to a nutrition basis as well. Family history is very important, but ultimately, prior to me seeing a couple, it's finding out whether they're going to work, whether we're going to be able to work together as well, because of my own sort of ways that I would consider that would be the best way to work around this. It's like, I've done the research, I've done the study, I've seen it happen. If you're ultimately going to dig your heels in and say no, but still want the outcome, then that's something we have to sort of discuss together. But if we're looking at labs, we're looking at serum, we're looking at hair mineral analysis, stool testing. For men, it's the profile of all their heavy metal toxicities as well as the sperm. It's a whole spider web of testing that can happen during this process, and whether it starts straight away or 3 months in is something that I work with them depending on what background they're coming from. Is it a first pregnancy, a second pregnancy, miscarriage history, all of those details.
Do you find with men who have sperm issues that there is often, always, an issue with heavy metal toxicity or some other toxicant? Like, for instance, I mean, we've got CCA from copper logs, so chromium, copper, arsenic, but there's also the persistent organochlorine pollutants, the POPs, which have, bind to aryl hydrocarbon receptors, So do you find a distinct correlation with occupation of males with regards to toxicants, or do you find that we're just living in a toxic world, and even, a sales executive driving around in his car all day will have toxic issues, an executive as the welder, is there any correlation that you see, or do you find that you see occupational specifics?
There's definitely occupational specifics. And as you said, whether it's the landscaper coming in or it's the businessman, they both have their own, pros and cons of how they live their life and lifestyle. We definitely already live in a toxic world, so that needs to be addressed. But it's the simple things. It's the blue light. It's it's our environment, the air we breathe, the food we eat. It's, that's such a big foundation. And then their profession is sort of the extra box that has to be looked at, because, as I said, is it the mobile phone in the trousers? Is it the laptop on the knees? Are they actually getting any vitamin D from the sunshine? Like, it's a myriad of things, but definitely when it comes to heavy metals, men like women, we have the ability to store it, and we drink from plastic bottles. And do you sweat? Like, it's simple questions like that, because it's lymphatic. It's, a gentle detoxification every day is good for everybody.
And because of our burgeoning waistlines, we know, I think Australia was 5th at one stage. There was some tout that we had won the fattest nation on earth some years ago, but I think thankfully we've lessened. I think Mexico is the worst at the moment, but we've certainly got burgeoning waistlines. We've certainly succumbed to that most dangerous of words, which is convenience. Do you find that exercise, just pure movement, has a bearing on spermatogenesis and healthy sperm in males? You're talking about sweating, for instance.
Yes, without a doubt. And I like to tell my clients that stagnation, no different to a river that doesn't move. If we have stagnation in the body, then things are going to accumulate that we don't want there. So moving is a big part of everyday life to actually get things, circulating. But sweating, for instance, is just, we know that if somebody sweats, that there's a gentle detoxification happening all the time, because skin is one way to eliminate excess.
Gotcha. Okay. So do you advocate even just mild exercise for somebody who's beginning this journey and isn't used to physical exercise, even just exercising together with their partner, doing some yoga stretches? I mean, heaven forbid they'd go for a run, but maybe. But, cycling, things that don't just end up being an exercise, but also end up being a meeting, a connection as partners for them. Do you advocate that sort of thing for them?
Yes, without a doubt. Particularly those, I've had couples who don't exercise at all, and they've come to see me, and I say, well, the first things first, can we start a daily walk? Is there something where you two can meet in the middle, for instance, whether it be, some men definitely aren't interested in yoga, but maybe Pilates might be something, because even Pilates and the diaphragm and the abdominal breathing, that's a really good massage for that particular region of the body, particularly for a woman. You're massaging all those internal organs, and no different to acupuncture when we sort of put a little bit of pressure somewhere and we circulate the blood. It's very healing. So anything they can do together is, and get a little bit of, heart rate up there, that is very beneficial.
I loved doing Pilates. I thought it was hilarious that we have this vision, certainly males might, that there's this graceful raising of the leg and things like that. I've never sweated so much in my life. Thank you, Sarah, down at Tugan. But there was also a lot of swearing, like, oh, crap. When I'm trying to, well, we are not flexible. Forgive me. Sorry,
No.
Kate.
I was going to say, and cramping probably too.
I could not believe the things that women can do as movements that males, it's embarrassing. But anyway, so you mentioned blue light and things like that, laptops on the thighs and mobiles in the pockets. Thank God we've grown out of the era of tight jeans. We're now in the grunge era where things are loose. So there isn't that constraint of the testicles, and which has got to do with temperature and affecting spermatogenesis. But what other simple things do males really need to do? And forgive me for harping on males. I'll go into the female portion tick. But what are the simple things that males really, really need to take notice of when they're looking after their sperm so that they can deliver the best option to be chosen by their female partner?
When it gets to the nitty-gritty, not only is it, your basics of nutrition and hydration and what are you exposed to, it really comes back to frequent ejaculation. Old sperm's no good to conception. We need constantly that sperm renewal, and that comes from every 2 to 3 days of an ejaculation, so that things start to get moving. So it's a part of the preconception for men.
Now, therein lies an interesting thing. If you're talking about a male who comes from a toxic environment, let's pick on welders. Is it advisable that they have frequent ejaculation, at least first, to get rid of the old sperm, rather than resorbing that tissue to be recycled into new sperm? Is it better to just get rid of that while they're preparing their bodies for the pure, best, healthy sperm, again, to be chosen by a healthy ovum?
Definitely. So we can look at all the nutrients, we can look at everything to support, but frequent ejaculation will help rid what you don't want, rid what you don't need.
Yeah, that's right. Now, females don't have that option. So how then do we best manage the female's health, the woman's health, with regards to healthy ova?
So healthy ovum, so we're looking always at the quality, and that comes from, so we're looking at the exposemo science of environment, foods, what sort of goes into our body, but also what's going to assist in that mitochondrial event, that huge event that requires so much energy. And that comes from making sure we're not in a depleted state. It looks at the history of medication, history of illness, how much inflammation is in the body. Is the immune system strong? Because these are all things that we know are compromised during pregnancy. And that's, I guess, my key message is to people is the biggest contraindication or thing we're concerned about is that women don't just get to that positive pregnancy test. It's about, it's the thriving pregnancy and the thriving baby. So they're one thing that I make sure I really sort of give that strong message about. It's not just this positive pregnancy test. We need to make sure that everything from here on, particularly in first trimester when there's so much happening in the body, that there's all those adequate stores to make this child to be a healthy adult, to be a healthy human being later in life, not to have worries of trisomies and things like that, other complications that will go on in the pregnancy, let alone with the baby when they're in the outside world.
Yeah. There was something I read years ago, and that was actually, I think it had to do with folic acid. Now, here's a can of worms about folic acid versus folate. And the issue of potential unmetabolized folic acid. This is something I'm only just learning about, so forgive me. But I learned many, many years ago when we didn't have the choice of folate metabolites, active folic acid metabolites, that folic acid, adequate folic acid, was actually helping a woman's body to enable what's called teratosthesia, i.e., if there is a damaged ova, blastocyst, that it was actually, although it's a horrible process for a woman to go through a miscarriage, it was actually a protective mechanism to say, I'm sorry, this blastocyst, this fetus is damaged. It wasn't going to fare well. We have to eject it. So along that lines, how much do you concentrate on folate metabolites, B12, versus general nutrition versus specific stuff for, toxicants and things like that? I guess this is a timeline question. Where do we go from here? That's a very convoluted question, Kate. I'm so sorry.
It's completely fine. So I guess when it comes to folate, folic acid, methylfolate, we have come a long way. So it was in the early 1990s that we realized that women who were supplemented with folic acid or folate or had adequate in their diet, that we prevented a lot of neural tube defects, which resulted in either miscarriage or had to result in an abortion, sadly. So when we learned this, we definitely have jumped on the bandwagon and run. However, this is where it comes down to forms, and what we supplement with is, if we supplement with not the best form, then this is where something like folic acid can accumulate in the body and raise homocysteine levels. So if we have high homocysteine, that also unfortunately creates pregnancy complications. So when we're looking at particular forms, particularly like methylfolate, that's going to be much more beneficial to the body in the sense that it's much more reduced and absorbable. And then we also need things like B12, and again, in a form that's quite absorbable to the body, that's going to allow it to be utilized and create that methylation process that's really essential to, again, conception.
And what about other things like choline? We've got serine, we've got B6, we've got methionine. I'm just thinking about the whole methylation cycle. It's going around in my head, biopterin. Yeah. What do you think are the key nutrients we really need to concentrate on? And do you think it's worthwhile just giving a multi as an insurance type thing? Because there's been this concentration of, if you have a healthy diet, quote unquote, you don't need any nutritional supplementation. I've looked on the Australian Bureau of Statistics at the amount of both men and women who are deficient in even B6.
Yeah.
That warrants a multi.
Yeah. Yes, it does. And it's not just B6 and B12, folate, magnesium. Copper is essential in the iron recycling process, as is vitamin A, and that's something that we're, still trying to remedy the controversy of. along with your vitamin E, so your antioxidants, anything that's going to break down this damage, this oxidation, which is very important, again, when it comes to the older you are with conception. And let's be honest, a lot of people are conceiving later in life, and where there's a unrealistic, in my view, reliance on medicine to warrant that, because you're right, it's not just, I meet people who have this incredibly clean and immaculate and, magazine style diet. However, that's not feeding their body. It's looks good and it sounds good, but ultimately, if we're not meeting the fat requirement, the protein requirement, and even the complex carbohydrate requirement, our body works from almost a top-down approach when it comes to conception, because if our brain, when it comes to the HPO axis or the HPA axis, if our brain does not feel safe, secure, then ovulation might not even occur. So, if we want to continue down this rabbit hole, we even need to make sure somebody's ovulating. And if they're ovulating, is it an optimal egg that time, or are we still in a place of trying to replenish nutrients and stores due to medications or OCP or the PCOS, various conditions that come with, insulin resistance or cortisol awakening response? It's all disturbed because of blue light. So it's sorry, I've taken myself down a rabbit hole now, but it's just, there's so much important. But when it comes to choline, that's essential for mum's health, bub's health, in utero and postpartum particularly, as is DHA. They're all essential in wanting to create an optimal pregnancy and a thriving mum and a thriving baby.
I once had a conversation with a doctor who disdained vitamins, and I was asking him about the value of fish oil, and he said, I just tell my patients to eat fish. And I said, how's that working for you? So can I ask you, of the patients that you see, given that these are going to be patients more aligned to wanting change in dietary modification, how much acceptance, how many of your patients eat fish regularly? And I know that's a stat, but as a guess.
50% would.
Right. So there's 50% who don't, who require some sort of EPA, DHA supplementation. This is the thing that stuns me. With it's kind of like dietary guidelines. It's so, well, just eat that. They don't.
Exactly.
So how much work do you have to do on? It's not just reinforcing it; have to be beating people over the head about the usefulness of these nutrients. And if they're not going to get them from the diet, then they've got to get it from somewhere, and a supplement's the only answer if they refuse dietary modification. So what sort of stuff do you use, and how much do you have to beat them with it?
Absolutely, Andrew. So we start with a very nutrient-dense approach, firstly, and I am very heavy on supplements, I'll admit that straight up. But firstly, it'll be about foods and whatever goes into that, mouth of yours, what are we getting out of it? So it is a nutrient-dense approach, and how can we optimize what you're eating? Because even if it's a case of, I buy organic and biodynamic and, every label under the sun, if the soil's depleted, then the food's also going to be depleted. And that goes for meat as well. It's, it's not just your grass-fed and organic and free range. It's, if it comes back to the soil, then there's ultimately going to be a sort of depreciation there of availability. So the food first approach, and then it gets definitely topped up with supplementation. And that's also because of it's the energy required in this process. So the mitochondrial side of it. So that's with your CoQ10 or your ubiquinol. But then it comes back to the nutrient levels. So, we're not always going to get adequate, vitamin E and C and things like that from our diet. So having a a therapeutic prenatal is paramount in my opinion, because it covers those bases, because some days we don't eat as well as we should, and some days our body might be busy doing something else as opposed to absorbing nutrients, because it also comes down to a microbiome and a gut, and if there's any infections that are potentially preventing the absorption there. And we know with someone, if they've had a history of the oral contraceptive pill, there's definitely a depletion of nutrients that have perhaps been happening for 10 years that we need to look at, not just getting to a baseline, but getting to an optimal level. So again, this comes back to, in my preconception sort of conversation with people, is that I'd say this is going to be a heavy supplement protocol, and this is not just, for the case of me wanting you to buy 10 different supplements. It's about the health of you and the health of that child and the child's health for the next 80 years as well. So it's really trying to get people to, just let me guide you for a little bit so that we can make this the best experience possible.
Yeah, what you actually mentioned there was intergenerational health. And I actually spoke to Matt Muir, who's a vet, and he's talking about intergenerational health with pets, not just starting with the parent, but the grandparent of the thing that you need healthy. I mean, we've really got to expand our minds. Humans are horrible at this. We really need to increase. I love the way that you're talking about this. Well, it is. Like, we know that we've seen from what was it, DES, diethylstilbestrol, the effects on the daughters of the mother who took DES. So we know that these intergenerational health issues occur. Now we have to think about optimizing that health. It's wonderful that you're thinking about that. Now, we could spend all day on this pre-pregnancy stuff because seriously, it's a seminar, it's a book. So I'd love to have you back sometime on Wellness by Designs, but let's move on to postpartum care. Now, this is something that I'm a registered nurse. I thought I was going to be fine with helping my wife through her pregnancy and things like that. I was hopeless. I was absolutely hopeless. And talking about postpartum stuff, well, there's no rule book for that one. This is something that disgusts me with healthcare. Take us through what you find and what you've changed to help your patients after they have a baby, a healthy baby, which they've now got at home.
Yeah. So I work with my clients in third trimester on this because I know that it takes, you get the baby home, and again, there's a little bit of a preconceived idea that you can stop your multi, you can stop your prenatal, you can stop all those supplements that you took preconception and just put them by the wayside because everybody says, oh, your baby will get what your baby needs, or your body will make the milk that it needs to feed the baby, and it'll be nutrient dense. However, again, this comes back to, we don't like to offend people, because the reality is, and we know this, that if the mother is not consuming enough nutrients, the nutrients aren't going to flow onto the baby. If the nutrients aren't in the woman's body, there's nothing to flow onto the baby. And we've seen this with the level of fat a woman eats. Is the milk, what fatty composition does it have? We know this with DHA, we know this with choline, that even B12, and we know this from vegetarian and vegan mothers, that if they don't supplement, that there can be real detrimental sort of effects on the child that aren't able to be irreversible because of the effect that B12 has to the brain development of the fetus, but also the baby. So if those things are devoid postpartum, then it just creates this cascade of events. And that's not even bringing into it the anxiety and depression as a result of sleep deprivation, the cortisol disruption, insulin, which all of a sudden you crave all these carbohydrates because of the lack of sleep. And then the next day continue that roller coaster of, emotions and not getting out in the sunshine and wondering are you doing a good job? So it was interesting. It was my grandmother who told me this, that she had said, Katie, anxious mothers create anxious milk. And there was no science in that, but there was a lot of logic in it. And I could definitely find science in that now that I know what I know.
Mm. Oh, absolutely. Particularly as we're seeing with, subsequent siblings and the stress of motherhood and the effects that it has on further siblings. It's quite incredible what's coming up now. I love that you mentioned sunlight, because I can still remember, this is a book put out by the RACGP, the Royal Australian College of GPs. And it was called the Red Book. So it was basically a handbook of how to practice. And this is an older version, which has now been corrected. Thank goodness, because I can still remember this Red Book saying babies should receive no direct sunlight. Now, I get the issue. I understand the issue of sunburn. I mean, in the Queensland sun, I see people walking along the beach and I'm going, please put that hood down. Please, come on, it's baking. I get the issue of sunburn, but we are not moles. We live on the earth, not under it. It flabbergasted me that this was a handbook for good care. So I'm so glad you talk about sunlight, but with regards to cortisol, stress, and we could go off on here talking about a rabbit hole about men pulling their weight by helping the mum and having like a shift, if you like. Like Lee and I used to. Lee liked to get earlier sleep. I was a night owl, so I'd stay up until 12 or something, and Lee would do the earlier hours. But what other sort of practical tips can you give us and our couples to help ease the stress, manage the sort of regimen of raising a newborn baby?
Yeah, I would say ultimately it's have the plan. If you can have a plan, then you feel like you have a little bit of a safeguard, particularly when there's the brain fog from the sleepless nights. And I'll be honest, I don't always plan to educate the woman on how their partner or should play a role in this, because that can be a sensitive area. So I will go down the path of how can I help you best in regards to, is it having the meal prep ideas? Is it having sort of different places where you can ultimately get things pretty quickly? And for me, that always comes back to having their food and supplements on standby, because sometimes you can't control anything else, but what you can control is, what you put in your mouth each day, the amount of water you drink. Is it, if stress or anxiety or depression is even a concern from previous years and months before, then it's something we definitely need to consider going forward, and what support program can we perhaps look to that might help. And look, I've even investigated postpartum doulas for people that come in purely just for, the aid of the mother, for no other reason. So, and look, that is an unfortunate part of today's society. We don't have that village aspect we did probably 60 years, 100 years ago. So it is about making sure those tools are there. And ultimately, I feel if the woman feels good, we can work with that.
Gotcha. I mean, there's a whole lesson there for the extended family, which of course is eroding away, but more so nowadays. I think you're still in lockdown. You're in Sydney. So this is even compounded worse by not even being able to access family members that might offer you support. And therein, there lies this sort of increased risk of postpartum depression, PPD. Tell us a little bit about that. How do you help women manage that or look out for red flags? And what indeed are you finding the effects of COVID-19 on mental health in your couples?
Yeah, I found it was a lonely experience for a lot of women, particularly, and the couples, particularly if they had for their first child, but also if they'd had difficulties getting to that point of bringing home a child as well because of losses previously. Because let's be real, nothing prepares you to bring home a baby or look after it or deal with sleep deprivation. Some people really, really need their sleep, and that is a question that I'll ask prior to them, about to give birth. I'm like, how is it? How are you going to go with sleep deprivation? Are you someone who really needs it? And they might say they're fine, but their husband absolutely needs it, or they're not fine, but their husband will be great, without a whole heap of sleep. So when it comes to depression, I ultimately will go heavy on supplements. I'll go heavy on their essential fatty acids. I will keep that inflammation low. Inflammation low, because it's a case of, we know that when that's all exacerbated and the hormones are going, a roller coaster ride after birth, they drop off very quickly, and it can ultimately leave you feeling pretty scattered and depleted because of that really quick effect of having all these feel-good hormones to a baby in your belly to there in your arms, and now you're sleep deprived and you're feeling pretty, dehydrated and exhausted. So it's a case of really looking at essential fatty acids to ultimately, anything for the brain that's going to help it recover and replenish.
Okay, so PPD, tell us a little bit about the red flags. Do the red flags for postpartum depression appear at birth with a lack of bonding, or concern in the mother that they're not bonding with their baby? Or do you see them occurring later on, or is there just a whole spectrum going on? Tell us a little bit about what you look for.
Look, there's a whole spectrum, and when it comes to how they sort of, PPD can be diagnosed up until 12 months postpartum, and this is due to the effect of, again, up to 12 months you can still have PPD, and this is because of nutrition depletion and how it gets worse with sleep deprivation and obviously not looking after yourself the same way you did prior to conception. So look, somebody can come to me and say they suffered depression in their 20s, and that's an easy red flag to go, okay, we can work with this. Somebody else has come to me who has been trying to conceive. They've been on antidepressants or SSRIs, and the only way they've been able to conceive is to come off them, and that's due to a whole nother hormonal cascade effect that SSRIs do on the, HPO axis. But it's the case, what hits hardest are the people who have no history of depression or anxiety, and they might not get it in those first few days of baby's birth, but they might get it 2 months later, because 8 weeks, between 6 and 8 weeks, there's another real big drop of hormones. And also that sort of tends to mark the time frame where a lot of people stop checking in or families start dropping off. So given COVID-19 and people potentially, A, didn't want people round to visit the baby, but B, people haven't had mothers or mother-in-laws or friends to come around and even just make a cup of tea. There's been a real sense of how do we make these women still feel like they've got a support network when it's all done virtually. And to be honest, it's hard, Andrew. Like there's no way, people can always put on a front, and COVID-19 has allowed people to potentially put on that front and get away with it much easier. And that's the hard part. There's much more out of our control now.
Yeah. Kate, there is so much that we wanted to cover, so much more than what we wanted to cover today. I would like to invite you back so that we can go through doses, a particular case history, and indeed maybe delve into if males get postpartum depression and some other issues. But just as a last quick question, so that at least prackies can have some direction, some future direction for learning, what sort of references, what resources do you rely on? Do you recommend people learn from?
for practitioners particularly, you're always coming back to, the endocrine health, and that's whether it's, listening to podcasts by Carrie Jones, who's amazing, or Chris Master John is a nutritional biochemist. He really gets into the nitty gritty of pathways and feedback loops, and they're wonderful people to check out. But then if you're really looking at a nutrition sort of side, it's Lily Nichols. But, there's so many experts now in our field, and it's wonderful because we can't all cover the one topic adequately. We come from it from different angles. So, they're my top three go-tos.
Brilliant. Kate Carr, thank you so much for taking us through. This is such an important topic, one that for years has just languished. We haven't had any postpartum support, which you're giving to your patients out of good care. And thank you for your care of your patients. Well done to you. But thank you for joining us on Wellness by Design today.
Thanks, Andrew. It's been a pleasure.
And we welcome you back soon. So thank you, everyone, of course, for joining us today. Remember, you can catch up on all the other podcasts. We'll put up the show notes, of course, to today's podcast on the designsforhealth.com.au website, including some of those reference materials so that you can learn. And remember that we'll be back with another podcast with Kate Carr later. So thank you very much. I'm Andrew Whitfield Cook, and this is Wellness by Designs.